Mitral stenosis, chronic rheumatic heart disease with mitral stenosis with atrial fibrillation with pulmonary hypertension. Differential diagnosis is ASD left atrial myxoma. Why it is atrial septal defect? Opening snap may mimic fixed and wide splitting of S2. First heart sound may be loud due to increased flow through the tricuspid valve. There may be mid-diastolic murmur due to increased flow. Causes of congenital mitral valvular heart disease, they are parachute mitral valve, supravalvular ring in left atrium. What do you think about the causes of mitral stenosis in this patient? Chronic rheumatic heart disease. If history of rheumatic fever or prophylactic penicillin use. If no history, then defined as it is the most common cause of mitral stenosis. And up to 40 to 50% patient has no history of rheumatic fever. Causes of iatrogenic mitral stenosis after TAVR, mitral valve clipping. Frequency of mitral stenosis and other valve involvement in rheumatic fever. Most common mitral valve, then aortic, followed by tricuspid, rarely pulmonary. 25% have isolated MS. 25% have isolated MS. 40% has MS with MR. 35% mitral with aortic. 6% tricuspid valve. Pathogenesis of rheumatic heart disease. What is the cause of palpitation in mitral stenosis? Sinus tachycardia, then atrial fibrillation, SVT. How can you differentiate clinically sinus tachycardia, SVT, atrial fibrillation? Tachycardia is regular in sinus and SVT, but irregular in atrial fibrillation. Starts suddenly and ends suddenly in SVT, but in sinus it starts and ends gradually. In SVT, pounding sensation in neck. Causes of sinus tachycardia in MS due to reduced cardiac output, there is sympathetic overactivity. Effect or consequence of atrial fibrillation in mitral stenosis. Tachycardia reduces diastolic filling time, and due to loss of effective atrial contraction, LV filling is impaired. Increased LA pressure leads to increased pulmonary venocapillary pressure and then pulmonary edema. Ultimately results in symptoms of low cardiac output like fatigue, dyspnea, and symptoms of pulmonary edema. Note: in mitral stenosis, LV filling is mostly dependent on atrial kick. Thromboembolism leading into embolic complication like stroke 60 to 75%, peripheral vascular disease, and MI. Why atrial fibrillation in MS? Mechanism of atrial fibrillation in MS, in which valvular lesion AF is common, MS or MR. Why? Due to mitral stenosis, there is increased in left atrial side and left atrial pressure, resulting into myocardial stretch and structural change, fibrosis of left atrium. In mitral stenosis, LA pressure is increased throughout the systole and diastole. Your patient now in sinus rhythm. Can thromboembolism occur? Yes, F can be paroxysmal. 20% of thromboembolism occur in absence of atrial fibrillation. Due to LA enlargement, there is stagnation of blood in LA appendage. Why there is chest pain in mitral stenosis? Due to pulmonary hypertension and RVH. May be associated ischemic heart disease, pulmonary infarction due to pulmonary thromboembolism. Note: calcium embolization in coronary artery, especially if patient age more than 40 years. Why there is dyspnea? Dyspnea occurs due to elevation of left atrial pressure and pulmonary venous hypertension, which leads to reduced compliance of the lungs, a decrease in vital capacity, and increased work of breathing. reduced cardiac output and tissue hypoxia, pulmonary hypertension, reduced dyspnea. Which condition worsen dyspnea? Exercise, pregnancy, fever, atrial fibrillation. What type of failure occur in mitral stenosis? Right heart failure due to pulmonary hypertension and left atrial failure. Mechanism of left ventricular failure in MS. Chronic rheumatic heart disease process involving left ventricle. Increased afterload due to sympathetic overdrive, low cardiac output, impairment of LV failing due to stenosed mitral valve, LV reverse remodeling, associated coronary artery disease, and LV dysfunction. What is the functional status of the patient? Cause. What is the functional status of this patient? Causes of hemoptysis. Massive hemoptysis due to rupture of bronchial vessels, mainly during exercise. Pink frothy due to pulmonary edema, pulmonary infarction, anticoagulant in lung case if AF and patient gets anticoagulation. Cause of hoarseness or Ortner syndrome due to huge enlargement of left atrium, compression of the recurrent laryngeal nerve leading to hoarseness. Pulse. Irregular pulse due to atrial fibrillation. In sinus rhythm, low volume pulse due to reduced cardiac output. JVP. The jugular venous pulse may show a prominent A wave in the presence of pulmonary hypertension. With atrial fibrillation, the A wave and X descent are absent. Why first heart sound is loud? Because of high left atrial pressure, the mitral valve remain wide open throughout the diastole. So when in systole closes the valve from its fully open albeit stenotic position, creating a loud first heart sound. How is the first heart sound in AF? In AF, intensity of first heart sound becomes variable with louder first heart sound in short cycles. Differential diagnosis of variable intensity first heart sound: atrial fibrillation, complete heart block, AV dissociation due to any other cause. Differential diagnosis of loud first heart sound: mitral stenosis, hyperdynamic circulation, LA myxoma, ASD. Can first heart sound soft in MS? In severe calcified MS, there is very little motion of valve leaflets, so first heart sound becomes soft. With why opening snap? Due to sudden tensing motion of the thickened valve but pliable mitral valve leaflets during opening. Significance of opening snap: it is clinical clue that mitral valve is pliable and PTMC can be done. What is the significance of opening snap? It is a clinical clue that mitral valve is pliable and PTMC can be done. How and where opening snap is heard? By the diaphragm, as it is high pitch sound between parasternal area and apex. At the apex, inching method. Differential diagnosis of opening snap: splitting of second heart sound, third heart sound, fourth heart sound. Most reliable sign of mitral stenosis: opening snap or presystolic accentuation not present in F. Mechanism of presystolic accentuation: due to atrial contraction at the end of diastole. What is the mechanism of presystolic accentuation? Due to atrial contraction at the end of diastole. Sign of severity of MS: first heart sounds soft or inaudible, increase in duration of murmur, reduced distance between S2 and opening snap, evidence of pulmonary hypertension. Causes of mid-diastolic murmur: mitral stenosis, tricuspid stenosis, left atrial myxoma, Austin Flint murmur, AR. In case of AR, Austin Flint murmur. In case of AR, Austin Flint murmur. In case of AR, Austin Flint murmur. Kerry-Coombs murmur, acute rheumatic fever due to increased flow in cases of VSD, PDA, ASD. What are the low pitch sound, diastolic sound? Mid diastolic murmur, third heart sound, fourth heart sound. How MDM of MS can be differentiated from MDM of AR? Presence of opening snap and presystolic accentuation in MS, peripheral signs of AR in AR. How MS can be differentiated from left atrial myxoma? In left atrial myxoma, murmur intensity changes with position to position and examination to examination. Tumor plop may be present. Now, ECG findings. If the patient is in sinus rhythm, wide P waves may be present, indicating LA enlargement, P mitrally. Tall R waves in the right precordial leads may be clue to RV hypertrophy. P pulmonary may be present when there is pulmonary hypertension. Features of atrial fibrillation can be found. Chest X-ray, upper lobe pulmonary diversions, that is cephalization of blood flow, and Carlis B lines, straightening of the left heart border as a result of prominent left atrial appendage, dilated pulmonary artery, and underfilled aortic knuckle. Double right heart border, widening of the carinal angle. Why cephalization? What type of pulmonary hypertension? Pulmonary venous hypertension. What does Carlis B line indicate? This is thin line 1 to 2 cm in length, perpendicular to pleural surface due to prominence of interlobular septa. Prominence of interlobular septa in pulmonary interstitium. Carlis A line 2 to 6 mm, oblique line thicker than Carlis B line, and of course towards hyla. Carlis C line short line that does not reach pleura. Echocardiography. What are the objectives of echocardiography in mitral stenosis? To establish the diagnosis, to determine the etiology, to quantify the severity, to detect concomitant other valves involvement, to assess suitability for balloon mitral valvotomy, to detect hemodynamic consequences such as LA enlargement, RB enlargement, pulmonary hypertension, left atrial thrombus. Findings of echocardiography in mitral stenosis. In case of M mode, decreased or flat rate of diastolic closing of AML, that is decreased EF slope. Reduced DE excursion, anterior motion of posterior leaflet in diastole, loss of A wave. 2D echo, parasternal long axis view shows leaflet thickening and calcification starting from tip, reduced mobility of leaflet, diastolic doming of anterior mitral leaflet or hockey stick appearance, changes in subvalvular apparatus such as caudal thickening, shortening and fusion, thickening and calcification of papillary muscle, presence of MR or aortic valve disease, LA enlargement, RV enlargement, LA thrombus or spontaneous echocontrast. In parasternal short axis view, we can see commissural fusion and calcification, in that is fish mouth appearance, mitral valve area measurement by planimetry, better visualization of LA appendage, flattening of interventricular septum and D-shaped LV, and large major pulmonary artery, right pulmonary artery and left pulmonary artery. What can we see in apical four-chamber view? Doppler assessment shows mean gradient, pressure half time and valve area. Mitral valve area 220 divided by pressure half time. Pulmonary artery systolic pressure by TRZ. RB function assessment. Subvalvular apparatus best assessed by parasternal long axis view and apical three-chamber view. Echocardiographic assessment of mitral stenosis severity. Valve area by planimetry when it is less than 1.5 cm square. pressure half time more than 150 millisecond, mean gradient more than 10 millimeter of mercury, pulmonary artery systolic pressure more than 50 millimeter mercury. How can you assess echocardiographically whether PTMC can be done? If Wilkins score is less than 8. Components of Wilkins score is leaflet mobility, leaflet thickening, leaflet calcification, and subvalvular apparatus. Indication of transesophageal echo to exclude left atrial thrombus to better visualize subvalvular apparatus and MR. What is the complication of mitral stenosis? Thromboembolic manifestation, stroke, pulmonary hypertension resulting in right heart failure, atrial fibrillation, massive hemoptysis. Medical management of mitral stenosis includes diuretics, beta blockers, digoxin or heart rate regulating calcium channel blocker. Phenoxymethylpenicillin anticoagulation with a target INR between 2 and 3 is indicated in patients with either new onset or paroxysmal atrial fibrillation. Indication of anticoagulation in MS. Atrial fibrillation, past history of thromboembolism, LA thrombus or spontaneous echo contrast in LA enlargement more than 55 millimeter, LA enlargement more than 55 millimeter. Why NOAC not used in MS? In the large RCT for NOACs, moderate to severe MS patients are excluded and the thrombotic risk of MS is high, so still warfarin is used in this setting. Name some RCT for NOAC. Rocket atrial fibrillation trial for rivaroxaban, Aristotle for apixaban. So rocket atrial fibrillation trial for rivaroxaban, Aristotle for apixaban. Indication of intervention in mitral stenosis. Symptomatic severe MS, asymptomatic severe MS with high risk of hemodynamic compensation like pulmonary artery systolic pressure more than 50, planning for pregnancy or major non-cardiac surgery, asymptomatic severe MS with high risk of thromboembolism, look above, asymptomatic very severe MS, symptomatic MS with mitral valve area more than 1.5 but exercise induced decompensation, mean gradient when more than 15 millimeter mercury. Contraindication of PTMC, valve morphology not suitable, high Wilkins score more than 12, bilateral commissural calcification, left atrial thrombus more than trivial MR, severe concomitant aortic valve disease or coronary artery disease requiring surgery, no commissural fusion, valve area more than 1.5 centimeter square. Now, what are the complications of PTMC or life-threatening complication of PTMC complication that needs immediate surgery? The most important complication is mitral regurgitation. Other complications include ASD, cardiac perforation, tamponade, vascular access site complication, thromboembolism, stroke. Criteria of successful PTMC. Clinically, how can you assess successful PTMC? Sensation of relief of chest tightness and breathlessness, MDM duration reduce or disappear, increase in systolic blood pressure. First heart sound may remain loud, pansystolic murmur may appear not more than mild MR. Mitral valve area increased by 50% and it is more than 1.5 centimeter square. Pulmonary artery systolic pressure reduced, transmitral gradient reduced. Which balloon is used in PTMC? Inouye balloon. What are the surgery that does in MS? Closed mitral valvotomy, CMV, CMC, open mitral valvotomy or commissurotomy, OMB or OMC, mitral valve replacement. Now, what are the indication of surgery in MS? Symptomatic severe MS, where valve anatomy is not suitable for PTMC or not available. How open mitral valvotomy is done? Done under cardiopulmonary bypass, splitting the papillary muscle chordae tendineae, debridement of calcium deposit, LA thrombus removed, LA appendage amputated. Advantage of open mitral valvotomy: it avoids prosthetic valves, so anticoagulation not needed. Operative mortality of MBR is more. Mitral valve replacement operative mortality is 3 to 8%. Direct visualization and thrombus removal. Anticoagulant during pregnancy. First trimester will use unfractionated heparin, low molecular heparin. Second trimester warfarin. From 36 weeks, stop warfarin, give low molecular weight heparin. 12 hours before delivery, stop low molecular weight heparin, give unfractionated heparin. Stop unfractionated heparin 4 to 6 hours before delivery. Restart heparin after delivery when hemostasis is ensured. Stop warfarin concomitantly and stop heparin when INR is stabilized. Start warfarin concomitantly and stop heparin when INR is stabilized. So start warfarin concomitantly and stop heparin when INR is stabilized. Severe MS with NYHA class 3 to 4, pulmonary artery systolic pressure more than 50 mm mercury. Thank you.